Good afternoon. My name is Jilalu Asmera. I'm a pulmonary and critical care physician at Baylor University Medical Center in Dallas, Texas. The topic of our discussion today is anti-inflammatory and antithrombotic agents in COVID-19. Disclaimer, I don't have any conflict of interest with any of the products that are mentioned in this presentation, financial or otherwise. We'll start off with a case presentation. So the case I have is a 63-year-old man who presented with dyspnea of 3 days after testing positive for COVID-19 5 days prior. His oxygen saturation was 87% on room air, and the chest x-ray showed bilateral interstitial infiltrates, as you can see on the x-ray depicted. So the question is, which of the following reduces mortality in this patient? Is it ceftriaxone and azithromycin, or B, remdesivir, C, dexamethasone, D, hydroxychloroquine, or none of the above? So we'll start our discussion by looking into the relationship between inflammation and infection. Inflammation, as you know, is a defense mechanism of our body against any injury, including infections. And as such, when appropriate and controlled, it's a protective and helpful mechanism. However, uncontrolled excessive inflammatory response may be more harmful than the initial insult itself. Anti-inflammatory therapy in COVID-19 has multiple rationales. The first one is that clinically, patients with severe and critical COVID-19 can develop a systemic inflammatory response that can lead to lung injury and multi-system organ dysfunction. There are also numerous observations of presence of high levels of inflammatory markers like C-reactive protein and ferritin in patients with severe or critical COVID-19. So based on these observations, it's been proposed that potent corticosteroids might prevent or mitigate these deleterious effects. So to look into this possible hypothesis, we look back into history of pulmonary infections with different agents and use of steroids. The first evidence of benefit from steroids in pulmonary infections comes from the study of Pneumocystis jirovecii pneumonia, or formerly called Pneumocystis carinii pneumonia, with hypoxia. So when patients have PJP with hypoxia, prednisone has been shown to reduce mortality. This was a study done more than 30 years ago, and it's still what we practice. But some other pulmonary pathologies, including the Middle East Respiratory Syndrome, MERS, the severe acute respiratory syndrome, SARS, and influenza. In these scenarios, steroids have been shown to be associated with worse clinical outcomes. So based on just these two observations, you can see that there is a lot of potentially conflicting outcomes expected with the use of steroids in different clinical scenarios. The other evidence of benefit from corticosteroids is seen in patients with ARDS, irrespective of etiology. Steroids in ARDS have been investigated for several years by different studies with conflicting results. Some studies showed benefit, others showed no benefit, and even others showed some harm by use of corticosteroids. And the most likely reason for these differences is use of different methodology, research methodology, different doses of steroids, and different duration of use of steroids. However, meta-analysis of randomized controlled trials, multiple randomized controlled trials, was done and was published in the Intensive Care Medicine 2016 by Meduri and others. which proved that prolonged corticosteroid treatment is associated with improved outcome in patients with ARDS. So this data by itself would mean that maybe patients could benefit from corticosteroids in COVID-19 when they have severe or critical COVID-19 disease. In most of the times when they have the critical COVID-19 disease, they would fulfill criteria for ARDS. So this can be another reason to justify potential benefit of corticosteroids. However, it's very important to remember that the more closely related viruses, MERS and SARS, have shown no benefit with the use of corticosteroids in the past. So that kind of makes it harder to make any conclusions in managing patients with COVID-19 with steroids. So what did we do? So when the COVID-19 pandemic started, we started to see cases in the US, towards the end of February and beginning of March. And at that time, the overall consensus, without any studies obviously, was that steroids should be avoided in patients with COVID-19 based on the experiences with MERS and SARS. And these two diseases are known to be closely related to COVID-19. So at that time, we even avoided use of steroids in patients with severe or critical COVID-19, even when they have other indications for steroids, because we were concerned that the steroids could make the disease worse. However, a couple of months into the pandemic, experts throughout the world started to observe that most patients with COVID-19, especially those who have severe or critical COVID-19 disease, have marked signs of hyperinflammatory markers like CRP and ferritin, which are markedly elevated. And these elevations were associated with worse evidence of inflammation in the lungs, worse hypoxemia or ARDS, and overall worse outcomes. So in the absence of any randomized controlled trials, just based on expert opinions, we started using steroids for patients with very severe, the most severe forms of COVID-19 who were on mechanical ventilator and had severe hypoxemia. We used methylprednisolone for that because methylprednisolone was the steroid type that we used more widely for pulmonary inflammation, be it in COPD or other related pulmonary inflammations. So a couple of months after that, around June or July, early results of the clinical trial, which was testing steroids in COVID-19, was released. This study is called the Recovery trial, which was done in the UK. And this study showed benefit with the use of dexamethasone. So at that time, because our use of methylprednisolone was just based on expert opinion, and on the other hand, dexamethasone now has some support based on clinical studies, we started using dexamethasone for patients with COVID-19. So looking at some of the details of the Recovery trial, this was published in the New England Journal of Medicine earlier this year, but the early results were released in June or July of last year. So this is a study of dexamethasone in hospitalized patients with COVID-19. So these graphs show really very nicely summarize the results of, or the outcomes of the study. So the first is panel A, showed that all patients with COVID-19 and the endpoint for this study was 28-day mortality. And as you can see, the black line is for usual care and the red line is for dexamethasone. And although the difference is minimal, dexamethasone was associated with low mortality among all patients with COVID-19. This difference, although minimal, was statistically significant. The other panels show subgroup analysis. Panel B shows a subgroup of patients with COVID-19 who were on invasive mechanical ventilator. And as you can see, the difference between the black line and the red line now is wider, means the benefit of dexamethasone in reducing mortality was more pronounced in these patients, and obviously it was statistically significant. And in panel C, it shows a subgroup of patients who were just on oxygen, not requiring mechanical ventilator, and but just oxygen. And in these patients, again, dexamethasone was associated with low mortality. The difference was minimal, but still statistically significant. And the last panel, panel D, shows a subgroup of patients with COVID-19 who were not requiring any oxygen, who received dexamethasone. And in this group, actually dexamethasone was associated with higher mortality, although this was not statistically significant. So that there was a tendency to increase mortality, although it was not statistically significant. So this kind of was a breakthrough in managing COVID-19 patients, because this was, for the most part, the first definitive evidence of a useful therapy for COVID-19 disease. So when we summarize the results of the recovery trial, 28-day mortality for all patients showed mortality benefit with the use of dexamethasone. The number was small but significant. For patients on mechanical ventilator, the difference was significant, 29% versus 41%. It was really wider and obviously beneficial. For patients who were on oxygen, the difference was very minimal, 23% mortality versus 26%. However, this was still statistically significant. And for patients who were not on respiratory support, mortality was higher among patients who were on dexamethasone, 17% versus 14%. So going back to our earlier presentations, so this patient has evidence of COVID-19 with hypoxemia. So, and his chest X-ray showed that he had COVID-19 pneumonia. So which of these management decreases mortality was the question. So choice A is ceftriaxone and azithromycin. Generally, antibiotics are not recommended routinely for patients with COVID-19, especially if in non-critical patients, because the prevalence of supine post-bacterial infection in those populations is relatively low. Therefore, antibiotics have to be started based on clinical suspicion, either clinical or laboratory suspicion. So in this case, there was nothing that was suggested from the stem of the question to imply higher likelihood of this. So that's not the right answer. Remdesivir has never been shown to reduce mortality. There was some initial report of reduced duration of illness, but nowadays it's kind of falling out of favor. Hydroxychloroquine is actually contraindicated. It has been proven to be associated with more harm than benefit. So the answer is dexamethasone. So dexamethasone has been associated with improved mortality in this patient. The key is that he is hypoxemic and therefore he's requiring oxygen. And that means although the mortality benefit is small, there is still definite mortality benefit, and that's the right answer. So proceeding with the case presentation, how would you classify the severity of COVID-19 in this patient? So based on the information that we have, Is this a mild, non-severe, severe, or critical COVID-19? So this is based on the WHO recommendation for classification of disease severity, which classifies COVID-19 disease into 3 categories: non-severe, severe, and critical. So it's kind of a little bit unusual type of classification because we don't see any mild or moderate. So for practical purposes, mild and moderate disease is included. Clearly, the mild disease is included in this non-severe category. The moderate could be anywhere between non-severe and severe. But the WHO classification is based on respiratory issues for the most part. So patients who have non-severe disease have symptoms of COVID-19, including fever, cough, and things like that, but they do not have hypoxemia. Whereas patients with severe disease have hypoxemia as defined by oxygen saturation less than 90% on room air, or respiratory rate increase more than 30 per minute, or presence of other signs of respiratory distress. So if anyone with COVID-19 has these, any of these 3 evidences: oxygen saturation less than 90%, respiratory rate more than 30 per minute, or other signs of respiratory distress, these patients are labeled as having severe disease. On the other hand, if patients require life-sustaining treatment, including ventilator or vasopressors for septic shock, they are labeled as having a critical COVID-19 disease. So non-severe is no oxygen or no ventilator, kind of to simplify it. Severe is patients who require oxygen or are having signs of respiratory distress. And critical is patients who require more than just oxygen, namely ventilator or vasopressor support for septic shock. So based on this WHO classification, the answer for our question or for our case would be that this patient has hypoxemia, but the hypoxemia is not severe enough to require mechanical ventilator. Therefore, he would qualify for the severe disease. And as I mentioned earlier, the WHO classification does not have mild as part of the different types of or classes of severity. So it's just non-severe, severe, and critical. And our case qualifies for the severe disease category. So combining the two, the WHO classification of severity together with the results of the recovery trial, WHO recommends no corticosteroids for non-severe COVID-19. On the other hand, for severe and critical COVID-19, corticosteroids are recommended. Another way of saying this is that dexamethasone is indicated in patients with COVID-19 who either require oxygen or require ventilatory support. The dosage of dexamethasone is 6 milligram oral or IV for up to 10 days. So oral or IV depends on how sick the patient is or whether we have enteral access or not. But the dose is the same for both oral and IV, and it's up to 10 days, no more than 10 days, but it could be potentially stopped if the patient improved significantly during those 10 days of dexamethasone therapy. The study used dexamethasone, so that's a standard recommendation, but the anti-inflammatory effect of dexamethasone is also shared by the other steroids. So if dexamethasone is not available, it is assumed that the other corticosteroids will also be effective. So if dexamethasone is not available, you can use prednisone. The equivalent anti-inflammatory dose is 40 milligram daily, usually given once a day. Methylprednisolone is a little bit more potent, therefore the dose is 32 milligram daily. Or you can also use hydrocortisone at 160 milligram in 2 to 4 divided doses. So the half-life of hydrocortisone is shorter, therefore it has to be given 2 to 4 times per day. When we look at issues with pregnancy and in children, generally in pregnancy, dexamethasone is considered safe. This is based on studies or earlier experience with the use of dexamethasone for preterm labor to help with lung maturation, and it's been documented to be safe. Therefore, the recommendation is in pregnant women based if they have indications for dexamethasone based on the WHO recommendations, they can be given dexamethasone safely. The data in children is limited, but expert opinion and small studies encourage use of dexamethasone in children who are on mechanical ventilators. However, for children who are just on oxygen therapy alone, the evidence is very uncertain. Therefore, it has to be decided case by case. So other immunomodulatory agents have been tested, a number of them, some cell-based, some molecular agents were tried, and a lot of studies were going on throughout the world to assess effect of different immunomodulatory agents. So far, very recently, one of these immunomodulatory agents, or one group of these immunomodulatory agents, have been shown to have benefit in very specific group of patients. So this was based on this article on the New England Journal of Medicine, and that is interleukin-6 receptor antagonists in critically ill patients with COVID-19. So the background is that we said that COVID-19 is a very hyper-inflammatory disease, and some patients manifest with what looks like a cytokine storm or hyperinflammatory state, where interleukin-6 has been shown to be one of the most important players, cytokines. So it was proposed that if we could block interleukin-6 receptors, this inflammatory response could be decreased, and therefore outcomes could be better. So a study was done, the REMAP-CAP study, which tested COVID-19 among patients who were in the ICU and needing organ support, which by WHO disease severity classification would be the critical COVID-19 class, have been shown to be beneficial, has been associated with improved outcome among patients with critical COVID-19. And based on this, very recently, the National Institutes of Health, NIH, here in the US, has made recommendations for use of one of these agents, tocilizumab or sarilumab, for use as an anti-inflammatory agent or immunomodulatory agent for patients with critical COVID-19 disease. WHO does not have these recommendations yet. It could partly be because this is a very recent development, but it also is not widely available, and it's probably not going to be very helpful for the worldwide effort to control this pandemic. So the second part of our discussion is about antithrombotic agents in COVID-19. So we go back to our case and we'll follow up with a question. So which of the following is recommended to prevent venous thromboembolism, VTE, in our case? So A, is it screening for DVT with Doppler ultrasound of the legs? Or B, thromboprophylaxis with enoxaparin 40 milligram daily? Or C, full anticoagulation with either heparin or enoxaparin? D, checking D-dimer and decide accordingly? Or E, no intervention is needed. So we'll come back to this after some discussion of recommendations with regards to antithrombotic or anticoagulant medications. So just like inflammation and COVID-19, there is very strong association with COVID-19 and between COVID-19 and thromboembolism. The first observation is that coagulation abnormalities are common among patients with COVID-19. We see a lot of marked increase in coagulation parameters like D-dimer, fibrin degradation products or FDPs, and fibrinogen. And there is also evidence that some of these markers, especially D-dimer and FDPs, are increased more in patients who have more severe COVID-19. So they are generally increased in patients with COVID-19 and they are more increased in patients who have more severe COVID-19 disease. And so, the evidence for this comes from a study which was published in 2020, which showed that, as you can see in the red box, D-dimer, FDP, fibrin degradation products, and fibrinogen are increased in patients with COVID-19 as compared to controls. And the difference is really very significant. The next table shows that D-dimer and fibrin degradation products are actually proportionally increased depending on the severity of COVID-19. So in patients with non-severe disease, they are minimally elevated. In patients with severe disease, they are moderately elevated. And in patients with severe or critical disease, they are markedly elevated. So they are proportionally elevated. And from this, you could argue that patients with more severe COVID-19 disease are likely to have associated coagulation problems, including increased risk of thromboembolism. And this was confirmed by a study that showed that among patients who are hospitalized for COVID-19, about 14% of patients develop some form of venous thromboembolic complications. And this number goes up to a quarter, or about 23%, among patients with COVID-19 who are admitted to the ICU. So these are really significant proportion of patients requiring this kind of significant proportion of patients having these complications. The other important observation is that the patients who develop these complications tend to be those who have higher D-dimer levels. So the D-dimers appear to predict development of venous thromboembolism in these patients, as is the case in non-COVID-19 patients as well. However, we have to assess the risk and benefit of antithrombotic drugs or anticoagulant medications. And as you know, anticoagulant medications are a double-edged sword. They can help prevent thrombosis, but they also increase risk of major bleeding. So we have to balance this, and it's not very easy to balance this out and see which measure is favored in each individual patient. To complicate things, patients with more severe COVID-19 disease are at a higher risk of thromboembolism. And at the same time, these same patients are at a higher risk of bleeding complications. So those patients who you think would benefit most from treatment or prevention of thromboembolism are the ones who are also more likely to bleed and have complications from it. So these facts complicate the decision-making process with regards to anticoagulation of patients with COVID-19 disease. So because of that, and there are a lot of studies that have been completed and some that have not been completed, but based on current available peer-reviewed and published data, WHO recommends only thromboprophylaxis for hospitalized patients with COVID-19 disease. So if patients have COVID-19 disease and are not hospitalized, they don't need any antiplatelet or anticoagulant medications. But if they are hospitalized, whether it is for severe or critical disease, the current WHO recommendation is to put them on prophylactic dose anticoagulant medications only. However, WHO also notes that the risk of thromboembolic complications, be it venous or arterial, including stroke, deep venous thrombosis, pulmonary embolism, or acute coronary syndrome, these are all increasing in patients with COVID-19. Therefore, we have to be very vigilant, looking for evidences, and if there is any clinical suspicion, to follow that up with diagnostic and therapeutic decisions according to the findings of those investigations. But routine screening or routine therapeutic anticoagulation is not recommended at this time. It's just to say that there is no evidence at this time. So based on that recommendation, all patients who are hospitalized with COVID-19 have to be put on thromboprophylaxis for venous thromboembolism. The first line preferred agents are low molecular weight heparins like enoxaparin, given typically at a dose of 40 milligram daily. Alternatively, we can use unfractionated heparin, which is heparin 5,000 units given every 8 hours or every 12 hours, 2 or 3 times a day. Effectiveness-wise, they are comparable. The reason enoxaparin is preferred is simply because it's a once daily dose as opposed to heparin, which is 2 to 3 times a day. So it's more for convenience, for patient convenience. Enoxaparin is contraindicated when there is significant renal dysfunction with GFR less than 30, in which case heparin is recommended. So first line is enoxaparin unless patients have GFR less than 30, in which case heparin would be a preferred agent. For obese patients, patients whose BMI is more than 40, or for those who weigh more than 120 kilograms, then we have to increase the dose. Enoxaparin to 40 milligram every 12 hours and unfractionated heparin to 7,500 every 8 or every 12 hours. Additional recommendations. So those are WHO recommendations. The National Institutes of Health here in the US has additional recommendations, which are more details, nothing that contradicts the WHO recommendations, but they have made some additional recommendations. These include, with regards to lab testing, there is no data to support measuring coagulation parameters routinely. So we used to measure D-dimer and put patients on anticoagulation here in the earlier days, but studies have not shown any benefit of checking coagulation parameters like D-dimer, and then after checking it, what to do with it. So there is no recommendation and there is no direction. So at this time, they do not recommend checking those coagulation parameters. Patients who have been on chronic anticoagulant or antiplatelet medications for other indications should continue their antiplatelet or anticoagulant medication. There is no reason to stop those. For non-hospitalized patients with COVID-19, these agents are not recommended. We do not have to start them on any antiplatelet or anticoagulant medications as long as they have non-severe disease and are staying at home. Hospitalized adults with COVID-19, on the other hand, should receive prophylactic dose of anticoagulation as we discussed on the prior slide. And there are insufficient data as of today to recommend for or against higher than prophylactic dose anticoagulation. So this basically means higher than prophylactic dose anticoagulation is just simply to refer to either intermediate dose or full dose anticoagulation. So there is no data to support or to refute the benefit of this approach. Therefore, at this time, it's not recommended, but there are, as we will see on subsequent slides, there are studies that are coming up which might challenge this, but as of now, there is no recommendation to start anything higher than prophylactic dose anticoagulation. And there is also insufficient data to recommend or for or against routine screening for thromboembolism, regardless of coagulation markers. So even if the D dimer is high, unless it is clinically indicated, we don't look for DVTs or PEs, pulmonary embolism. So these have to be based on clinical suspicion. If you have clinical suspicion for any of these thromboembolic complications, which we know are more likely in patients with severe COVID-19 disease, we have to investigate and treat them accordingly. But just because they have COVID-19 disease, in the absence of any other indicator, we do not have to screen and we do not have to give them therapeutic anticoagulation as well. So coming back to our case presentation, so which of the following is recommended to prevent venous thromboembolism or VTE? So I think it's very clear now. So choice A, screening for DVT with Doppler ultrasound of the legs. Right now, there is no recommendation for routine screening. So that's not the right answer. Thromboprophylaxis with enoxaparin 40 milligram daily, that's the right answer. Full anticoagulation with either heparin or enoxaparin. Right now, there is no recommendation for that. Checking the D-dimer and making decisions based on the D-dimer, again, no evidence to support that. And the last option says no intervention is needed. That's also not true, because this patient has severe disease and therefore he's going to be hospitalized, and therefore thromboprophylaxis is recommended. So that's not the right answer. So the answer is thromboprophylaxis with enoxaparin 40 milligram daily. However, so these discussions were mainly focused on recommendations based from both World Health Organization and the National Institutes of Health, based on published peer-reviewed studies. However, new data is coming, and these new data have not been published, they have not been peer-reviewed, they have not even been, they don't even have a final analysis, but based on interim analysis of some of the studies, the most important of which is the ATT-ACC multi-platform randomized controlled trial, are showing some very compelling evidence for use of anticoagulant medications in selected patients. So I'll just share that. Very important to remind you that this is not a published data. This is not WHO or CDC or NIH or recommendation. No organization has made any recommendations on this, but this is coming up. Based on this interim analysis, there are some centers which have started to change their approach. So I'm just sharing this with you so that you know, you will be aware of these things that are coming up and that can change our practice. So this study was a multi-platform study and it showed that so the primary outcome for this study was organ support-free days, and what they actually found very interesting findings. The patients with severe COVID-19 by WHO criteria, here they call it moderate state. That's how the study defined it, but the moderate state in this study corresponds to severe COVID-19 from the WHO classification. And they found that use of anticoagulation is beneficial. So they showed that it's superior than not using anticoagulation in patients with severe COVID-19 disease. On the other hand, and this table shows mortality benefit in patients with moderate disease. As you can see, therapeutic for patients with severe COVID-19 by WHO criteria, therapeutic anticoagulation is associated with lower mortality. Whereas in patients with critical COVID-19 per WHO criteria, here it's labeled as severe disease, therapeutic anticoagulation is associated with higher mortality. So based on this, the interim conclusion, again, it's not final, but the interim conclusion is that in severe disease per WHO classification, for patients who are hospitalized but they are not on organ support, which basically is a WHO classification for severe COVID-19 disease, therapeutic dose anticoagulation is superior to usual care. Usual care would typically be prophylactic dose anticoagulation or thromboprophylaxis. And the risk of bleeding was not very significant in these patients. The second interim conclusion is that in patients with critical COVID-19, here they call it severe state, but by WHO classification, critical COVID-19 disease, therapeutic anticoagulation does not improve outcomes and may increase major bleeding significantly. And therefore, for patients who have critical COVID-19, they do not recommend using heparin or other full anticoagulation. So in summary, COVID-19 disease is associated with hyperinflammatory response, and that response could lead to significant injury in the lungs. And as you know, COVID-19 disease is primarily a pulmonary disease when it starts out. And of course, as complications keep going, patients go into a multi-organ failure state with renal failure, less commonly liver failure, encephalopathy, septic shock, and things like that. But it's primarily a lung disease, and most of the problem in the lungs is related to a hyperinflammatory response to the presence of COVID-19 in the lungs. And because of that, steroids, particularly dexamethasone, has been shown to improve mortality, and therefore is recommended for patients with severe COVID-19 or critical COVID-19. So the two worst types of COVID-19. So the only patients in whom dexamethasone is not recommended is a category which is non-severe. These are patients with COVID-19 who do not require oxygen or ventilatory support. The other important point is that for patients with COVID-19 disease who are hospitalized, which basically means WHO class severe and critical, the current recommendation is prophylactic dose anticoagulation with either enoxaparin or heparin. And as I said earlier, new studies are coming which suggest that full dose anticoagulation might be beneficial in severe disease and may be recommended for that subgroup. whereas it did not show benefit, or maybe more inclined towards harm in patients with critical COVID-19 disease. That's the end of my presentation. Thank you for your attention. Hopefully we'll have time to entertain questions related to my presentation. Thank you so much.